My name is Peter Forsberg. I'm an assistant professor at the University of Colorado. I'm a plasma cell disorders specialist, so I'm excited to learn about lymphoid malignancies from our wonderful panel of experts today. We really have a world-class group of providers here to share information on a number of interesting cases. So I'll ask them to introduce themselves. Dr. Pagel.
I'm John Pagel. I am not a plasma cell specialist. I actually focus on lymphoid malignancies, really exclusively do research and, of course, patient care in lymphomas and CLL, and I'm at the Swedish Cancer Institute in Seattle, Washington.
Hi, I'm Michael Thurman. Thank you very much for inviting me to participate in this tumor board. I'm on the faculty at the University of Chicago, and I specialize in lymphoid and myeloid malignancies.
Pleasure to be here again. Thank you. I'm David Schuster, and I'm a radiologist. I'm Division Director of Nuclear Medicine at Emory University in Atlanta.
61-year-old female with relapsed diffuse large B-cell lymphoma. This is occurring approximately 18 months after completion of systemic therapy and achieving a complete response on PET scan. So they were referred for consolidative auto stem cell transplant versus chimeric antigen receptor or CAR T-cell therapy. And so our main question in this scenario is going to be what our recommended treatment strategy is at this point. So the patient was initially diagnosed in early 2019, no compromise in their functional status, about 0. They had a history only of medical history of hypertension, which was well controlled, no tobacco, alcohol, or illicit drug use, does have a family history of a sister with lung cancer. So in 2019, they were diagnosed with stage 4 diffuse large B-cell lymphoma and treated with 6 cycles of R-CHOP without issue. Interim and end of treatment PET scans showed complete metabolic responses. In late 2020, they noted a new tender left thigh mass, and a biopsy was done on this. And this, again, demonstrated diffuse large B-cell lymphoma, positive for CD20, BCL2, BCL6, and MUM1. Negative for CD5, CD30, cyclin D1 or EBR. Ki67 was 90%, and FISH was negative for MYC rearrangements, non-GCB by Hans criteria. So they underwent 2 cycles of R-ICE, and this is our post-treatment PET-CT.
Sure, we're going to show these images, but we see the single focus on the left, the pre-salvage RICE, the large and intense left medial thigh mass. Then post-salvage, we see that there's been a tremendous response with a much smaller lesion, and now it's gone from Deauville 5 on the left to Deauville 4 on the right. A couple of points worth mentioning. Number one, all Deauville 4 is not created equal, right? So you could have a Deauville 4 like this, where you have 1 little lesion left, or you could have a Deauville 4 where you have 20 lesions that are distributed throughout the body, and they're just moderately greater than liver. So I know there's going to be a whole discussion about therapy, but one thing I'd like to throw out to my colleagues is, do you think it's appropriate at this point to biopsy that small focus of Deauville 4 residual disease to make sure that it is neoplasia and just not perhaps some inflammation?
Well, maybe I'll answer that. I think it's a really important question that Dr. Schuster raises, and I think we in the clinic battle this all the time. We always want to get tissue if we can. It helps us feel better. It certainly is prudent if we can do it. There's a lot of cases where we can't do it, and I would also say that there's a lot of cases where the risk outweighs the benefit, meaning are we going to learn something new or different? This is probably one of those cases where I would not biopsy this. Maybe Michael would feel differently, we'll see, but I wouldn't biopsy this because it's in a location of its original disease and it's responded. It hasn't gone away, but it's going in the right direction. If this had gotten worse or there were new lesions, then I'm really thinking, well, maybe this is something different. But the fact that we've gone from a very high SUV value to one that's relatively small, and Dr. Schuster, you're absolutely right. It's one of the points that we have to really stress. Not all Deauville 4s are created equally. So if you've gone from a high SUV value to a low SUV value, and you probably know better than I do, Dr. Schuster, there's of course data, using sum totals of SUVs showing that those things can be very, very important. For me, this patient had a very, very nice response, and I probably wouldn't biopsy this patient.
Mm-hmm.
Just to sort of specify, the patient looks like they had a greater than 90% reduction in the SUV from 53 down to 3.9. So pretty dramatic change in the SUV associated with that, what we can see on the imaging, obviously.
I agree with Dr. Pagel on this issue. I think, first of all, there's been a dramatic response. It's an isolated lesion, and it's not entirely clear that it would be possible to find that in an easy way and make sure that you're in the lesion because it's pretty small. And then also, there are issues of, whether or not that area is going to be radiated. So trying to do a surgical procedure for that when we're pretty confident that this is, what's left from an extranodal relapse. I think it would, of course, it's always nice to get more tissue, but I think in this case, it may not be worth pursuing.
Perfect. Well, so in addition to the imaging and the good response achieved based on post-RICE imaging, patients' labs show a white blood cell count of 4,800, hemoglobin of 9.2, platelets 116,000, normal renal and liver function, lactate dehydrogenase is 212, so within the normal range. And they've undergone screening studies with a normal transthoracic echo and pulmonary function tests. So, at this point, the patient has been sent specifically with a question of consideration for autologous stem cell transplant, CAR T-cell therapy, but certainly can consider any approaches beyond that in terms of this patient who relapsed, a little over a year from initial therapy with this primary focus of disease. So maybe I'll ask Dr. Thurman your thoughts initially on what your recommended treatment strategy might be.
Well, this is a controversial and difficult area. The patients had a terrific response. We know that they're at high risk of systemic relapse, and certainly autologous stem cell transplantation is well tolerated and would be feasible to do. I think the most aggressive course of action would be to do an autologous stem cell transplant followed by involved site radiation therapy. I think, just trying involved site radiation therapy would have a chance for cure, but would have a lower chance than aggressive therapy with a transplant. So I'd be curious to see what Dr. Pagel had to say about this case.
Yeah, I agree with you, Michael, in large part. I agree this patient should get a transplant. Their risk of relapsing outside of a radiation field is, still significant. I would certainly try to get this patient to a transplant, and hopefully stem cells were collected after that second cycle of ICE or RICE, or if they haven't, they should probably be collected around this time, perhaps just off of growth factor support, high dose growth factor support alone. I think one of the interesting things are really, around if you give some more therapy before going to the transplant. I think that's what Dr. Thurman was really kind of even saying about as well, the controversial part of it. Some people might give a third cycle of RICE before rolling into the transplant. There is, of course, support that would suggest that the less disease you have going into transplant, probably your better chance of success. I have seen people actually change the course of therapy. This patient does have what appears to be an ABC subtype large cell lymphoma that's probably responsive to an IMiD like Revlimid, and so you could perhaps give a little bit of Revlimid and rituximab if in fact more RICE seemed problematic. I have actually, in some cases, radiated even before a transplant. It's not something I typically do, but there have been some times where perhaps chemotherapy doesn't seem appropriate for comorbidities or the like, and so we've radiated before actually the transplant. Radiation after the transplant, I think Dr. Thurman raised us another very controversial point, and I have to confess that I usually don't do that. It's usually not my strategy. If the patient's in a PET negative remission after the transplant, I usually observe them because most of the data doesn't suggest that consolidated radiotherapy helps. However, in individual select cases, clearly it could be a benefit. And so I use that as kind of a case-by-case approach, and I suspect Dr. Thurman does as well.
What about the question of CAR T cell therapy in this situation? Is that changing, or is this an appropriate time for possible consideration of that in this setting?
Typically, CAR T cell would be in patients who have failed 2 lines of therapy, and so or failed autologous stem cell transplantation. So I would favor an autologous stem cell transplant in this setting. And then if the patient did progress again, then CAR T cell therapy would definitely be, the next or a very reasonable option.
Yeah, I completely agree. I would keep CAR T cell in my back pocket, just like Dr. Thurman would as well. But that's a moving target for us, to be honest. This patient had a 18-month remission after frontline therapy. That's actually still relatively short, but it can be worse, of course. You can have people that are primary refractory, meaning those are people that don't have a response to the upfront therapy, or they relapse within a relatively short time. And those patients we know don't typically do great with salvage chemotherapy and going to an autologous transplant. And I think Dr. Thurman's institution there at the University of Chicago, and we did as well, participated in the ZUMA-7 trial that people will learn a lot more about. And there's abstract or data now. We'll see this at ASH, and certainly press releases shown us that the ZUMA-7 trial was a randomized trial of CAR T cell therapy versus autologous transplant in these high-risk primary refractory patients, or patients who have relapsed within 1 year after frontline anthracycline-based therapy. And what the data suggests is that there was about a 30% reduction in the risk of events, or a 30% improvement in event-free survival after a follow-up of about 1.5 years, if I remember, if you got CAR T cells instead of autologous stem cell transplant. Now, we don't know if survival was really any different or not. We have to follow these people for a long time. That's the true measure of success here, because we're trying to cure these patients. But I think the field is going to evolve, likely in very, very aggressive patients, to be doing CAR T cells earlier, in fact, even in front of a transplant. But in this case, given the 18-month remission, I agree. I'd keep CAR T cells in my back pocket and hope you never have to use them.
Perfect. So to summarize, in this patient who's now relapsing with a primary focus of large B-cell lymphoma that's extranodal, responded after 2 cycles of RI salvage, primary thought would be to move towards a stem cell transplant, some potential to give additional therapy prior to transplant, potential role for radiation therapy, although if there was relied upon radiation therapy as the treatment, there'd be a high risk for relapse or systemic relapse. So the thought would be to come with a systemic approach with stem cell transplant, and some potential role for radiation either before or after that, although that's more controversial. And that CAR T is evolved, in this setting, but maybe a future role even in these slightly later but early relapses. This is a 63-year-old female with relapsed B-cell non-Hodgkin's lymphoma who presents at this point for salvage therapy in the setting of a new onset scalp mass, as well as fatigue and neck swelling. And so we're going to focus again on recommended treatment for this patient. So this is a patient that was diagnosed some time ago, 2015, diagnosed with stage 4 diffuse large B-cell lymphoma with extensive non-bulky lymphadenopathy and bone marrow involvement. Again, received 6 cycles of R-CHOP and achieved a complete metabolic response on interim and end of treatment PET CT scans. So now presents with a new scalp mass, and we'll take a look at what the imaging shows. Dr. Schuster.
So first on the MR, we could see a very large, enhancing scalp mass. It looks like it's infiltrating into the skull. And there are other areas like left frontal where you're also losing some of the normal fat signal in the skull. And then the PET scan was performed. So with the PET scan, we could see intense activity, Deauville 5 within the scalp lesion, as well as a lower right cervical node. And I believe on the report, there were some lumbar lesions as well and other foci in the skull.
So, this was biopsy and proven to show a recurrence of the diffuse large B-cell lymphoma. So in that setting with this later relapse with this fairly active, aggressive scalp lesion, as well as multiple foci of disease, recommendations on treatment approaches for next steps. I'll start with you, Dr. Payne.
Yeah, this is a tough case. I mean, I'm going to be very interested myself to hear what Dr. Thurman will say, because, what the right approach here is, no one knows. I think clearly this patient has a very worrisome presentation. I would guess, I don't remember if we have it from the history, but that this probably grew relatively quickly and does concern me, even though it's not, with clear parenchymal involvement. I would say I would be very inclined to want to get active and aggressive control of the disease on that scalp area, and I might ask for some early radiation intervention here before I do anything else. This is something that's going to, of course, require systemic therapy, and we can kind of talk about that. And I would likely lean towards originally a methotrexate-based approach early on, but first I might give a few doses of radiation to try and really get on top of this while we're getting a port placed and while we're kind of getting the patient teed up for treatment, perhaps. So maybe some radiation oncology would help us here. I would be inclined to want to give some methotrexate-based therapy. Now, I'll be honest, that may be overkill. I don't know, because we don't have true evidence of CNS involvement, but perhaps, I guess, the subdural is close enough. And so for me, I'm going to probably give something like part B of the hyper-CVAD regimen with methotrexate and Ara-C. I might actually do that for a couple of cycles and then come back with part A and do that for a cycle, another part B perhaps, something like that, then collect stem cells, and the goal would be to try to get this patient to a transplant. Michael, do you mind telling me where you see the flaw in my approach? Because I'm not sure it's the right approach.
Well, I agree with you. This is a very tough scenario. I think upfront radiation therapy might be challenging because it looks like there's such a large area involved. So it looks like you'd have to target quite a large area to begin with. I would like to, given the enhancement on the MRI, I think it would be worthwhile to obtain a lumbar puncture, check and see if there's any involvement of the CSF, which would, of course, be concerning and require intrathecal chemotherapy. I agree with Dr. Pagel's approach. I really like starting with the high-dose Ara-C methotrexate from the hyper-CVAD regimen. I think that's a very active regimen, and of course, it penetrates the CNS. And I think rather than starting with the more traditional chemotherapy part, I think starting with that makes a lot of sense. And I agree with getting the radiotherapists involved. I guess the question is, can they do the scalp and the skull safely, or is it better to shrink this tumor first? I definitely agree that this is someone that you would like to try to get to transplant and collect stem cells off of the chemotherapy, depending on how they respond. And then the question, and this is similar to our discussion on the previous cases, what's the best time to give the radiation? Is it up front or after the transplant or before the transplant when they've responded? I think it's tough, and I don't know that you can say definitively that there's a right or wrong approach.
Great. So, to summarize, this is a challenging scenario, unfortunately, with a pretty aggressive relapse concerning for active or potential CNS involvement, given it, the way that the lesion is moving through the skull on imaging. So I think that the recommended approach would be to start with lumbar puncture to evaluate further for CSF, demonstrating involvement, and involvement of the radiation therapist to weigh in potentially on the feasibility of radiation therapy early versus as a later portion of treatment, but then agreement on moving towards something like hyper-CVAD Part B to get good penetrance in this area and hopefully get control with a target after potentially a few cycles of that, maybe followed by Part 1 of hyper-CVAD to collect stem cells and move towards a stem cell transplant as a preferred target approach. Another relapsed diffuse large B-cell lymphoma, 75-year-old male now with relapsed diffuse large B-cell lymphoma, so a little bit older, presents with fatigue, lightheadedness, and pain. Again, we'll talk about treatment strategy. So this is somebody who was diagnosed in 2017 in the setting of stage 4 DLBCL with extensive involvement, testicular, osseous, splenic, and nodal involvement, received 5 cycles of R-CHOP, 6 doses of intrathecal methotrexate, was unable to receive the 6th cycle due to prolonged cytopenias at that time. On end of treatment, PET had a complete response and received consolidative radiation to the testes and left fibula. In 2018, developed hoarseness, and on laryngoscopy, they performed a biopsy which did show recurrent diffuse large B-cell lymphoma. So underwent a PET CT, was found to have FDG-avid lesions in the left humerus and non-bulky cervical lymph nodes, received rituximab and lenalidomide, PET CT with a complete metabolic response after 3 months of therapy. So that was in 2018. Now in early 2021, underwent a surveillance PET, and on that was found to have new FDG-avid lesions, underwent a biopsy of a liver lesion, which demonstrated diffuse large B-cell lymphoma, large neoplastic cells with pleomorphic nuclei, vesicular chromatin, prominent nucleoli, IHC positive for CD20, PAX5, BCL2, BCL6, MUM1, negative for MYC, CD10, CD30 or EBER, Ki67, 90%, non-GCB, subtype by Han's algorithm, FISH positive for BCL6 rearrangement, CSF evaluated with no evidence of lymphoma. So Dr. Schuster, I'll let you describe what you see here.
Sure. First, a general comment. The word surveillance was used, and I would like to advise never write the word surveillance on a PET order. Otherwise, you're going to find yourself doing peer-to-peer. So this patient is symptomatic, and that is why you're getting the PET. But this is an unfortunate case. Here we see widespread FDG-avid lesions, really thyroid, parotids, bilateral adrenals, also read the report, stomach, small bowel, spleen, perivascular, mesenteric soft tissue, prostate, penis, axial and appendicular skeleton, and of course the liver, and that was what was biopsied. And if we could see this also, this haze in the abdomen, and so I would suspect this patient has what I call peritoneal lymphomatosis as well. There's probably a lot of nodules. So we're talking about clearly and unfortunately extensive disease.
So now we have a patient who's relapsed after initial treatment with our CHOP, complicated by cytopenias, a relapse which was treated with about a year after diagnosis and treatment with rituximab and lenalidomide, and now we have a extensive relapse, about 2 years after that. So Dr. Pagel, what would you recommend as next steps with this patient?
Yeah, this is of course a challenging situation for many reasons. Yeah, I think the picture there on the right paints the most challenging picture we have. You know, when people present like this, even though you can see that there's not a lot of bulk to the lesions, they're numerous. And clearly, we've got a lot of extra, with what I assume is some extranodal involvement. I do think you're probably right. We have peritoneal involvement. You can't really tell if we have osseous involvement or not. It doesn't seem like it. Nonetheless, widespread aggressive presentation. And, you know, this patient's, I think, 75. He didn't get a transplant earlier. There must be a reason this patient didn't get a transplant. So he got R-CHOP, and then when he relapsed, he got R-squared and got actually a remission, or if I remember right, did well. That might have been the opportunity for a transplant if he was a candidate, but I'm going to assume he probably wasn't for one reason or another, and he's still not likely a transplant candidate. And frankly, transplant's not going to be highly successful in this setting, is my sense. This patient needs a CAR T-cell treatment. This patient has a chance still to be cured, believe it or not. If you look at, of course, the CAR T-cell data suggests that there's maybe about a 40% long-term survival benefit for patients, all comers at least, who are 2 lines of therapy, as Dr. Thurman mentioned, or failed an auto transplant. This patient would be eligible for a CAR. I think one of the questions is, what do you do between now and the CAR? Do you actually try to get disease a bit under control further before going to the CAR? I frankly would try that. I always feel that patients probably do better with the less disease going in. And clearly we know that those problems of cytokine release and neurologic toxicities that we associate with CAR T-cell therapy are related to the disease burden. So the less disease we can have in there, perhaps we can do a CAR as an outpatient in a 75-year-old patient. So, you know, this patient's had R-squared already. What do we do for this patient? I'm going to try and get this patient to maybe some salvage chemotherapy if they can tolerate it, just a cycle or 2. And it probably doesn't really matter exactly what you use. But we have a lot of other options here as well. And this is super controversial. I want to be clear about that. There are some salvage regimens that are new on the block. There's one that's a regimen of an anti-CD19 antibody known as tafasitamab. Tafasitamab is used in combination with lenalidomide. Probably wouldn't be my choice because this patient's failed lenalidomide. There's actually a new antibody drug conjugate targeting CD19 that I've used now a handful of times with really good success, which is localized. And that's another reasonable approach. Or perhaps even what might be even most appealing in this patient is the polatuzumab vedotin, that antibody drug conjugate in combination with a little bit of bendamustine and rituximab. Using those therapies to try to get to a CAR T-cell might be reasonable. If you can't get responses, you're still going to perhaps, hopefully, get this patient to a CAR and hopefully hit a big home run. There is controversy, though, to be clear, about using anti-CD19 targeted therapies up front of a CAR T-cell treatment, or we're also targeting CD19 with the engineered CAR T-cells. The data early, anecdotally almost, does suggest that that's a feasible thing to do and that it's safe and you'll be able to actually get good CAR outcomes with a prior anti-CD19 antibody. But I don't think the jury's really made a final decision there. So there's a little bit of risk and you're going to have to keep that in mind. I will just let maybe Dr. Thurman jump in if he has comments.
Well, I agree with everything that Dr. Pagel just said. I think this is a very high risk patient that he's failed 2 lines of therapy. It was mentioned that he was unable to get the 6th cycle of R-CHOP due to cytopenias, and that was early in the course of his disease. It might have made sense to go for an auto stem cell transplant at first relapse. and the decision was made to go with R-squared, which is a reasonable one. A lot of this depends on his performance status and comorbidity. So at 75, he's sort of at an age where it becomes tougher to do auto stem cell transplants and even CAR T-cell therapy. I think if you could get this man to respond, and I agree, I would not wait. I would start some sort of salvage therapy right now, since he already has fairly extensive disease. And I think the goal would be to try to get his disease under control before going to a more aggressive therapy, if that's what he wanted to do and his performance status would permit that. So if you could get him to CAR T-cell therapy, I think that would be great. And certainly people who have less disease, as Dr. Pagel point out, do much better than those who go in with full-blown relapse. I like the idea of some of the novel therapies that have been developed more recently, and I think it might be more realistic in a 75-year-old if they're not able to tolerate either CAR T or an auto stem cell transplant to look at bendamustine rituximab with polatuzumab. I think the response rates with that therapy are excellent, and the response durations are also reasonably good. So that would be a good way to go, I think, for someone in this situation.
Perfect. So, in conclusion, it's a patient who's unfortunately dealing with a fairly aggressive relapse, and, certainly their age and potential eligibility for certain treatments may color the treatment approaches that are preferred. Everybody sort of favors moving forward with treatment quickly and maybe preferring the use of some newly approved targeted therapies, including polatuzumab with bendamustine and rituximab. And if available, and the patient's sort of a functional candidate for it, CAR T would be the preferred approach, assuming that the patient is not a great candidate for transplant at this time. But even if they were maybe more in the transplant eligible category, CAR T may offer the best long-term outcome if that's achievable. So this is a 70-year-old male who develops a slowly expanding cutaneous 3 by 3 centimeter lesion on the scalp, which is biopsy-proven DLBCL, and it's consistent with stage 1E DLBCL. So we'll discuss how to manage this patient, and maybe specifically the question was asked, is this approach similar to what you might use in a primary cutaneous large B-cell lymphoma leg type? So here's our imaging. Dr. Schuster?
So as best as we can determine, this is more of a confined scalp lesion, as opposed to our other case where we really have that extensive infiltration. It's written that PET-CT showed no evidence of disease. It may be that the PET just didn't go that high. But I think what they're saying is that there's no other disease that you can detect with PET.
So, Dr. Thurman, any initial thoughts on how you would approach this patient and for therapy?
Presentations today, so it's interesting. I think when you're dealing with these extranodal cases, it's challenging, but I would favor a shorter course of R-CHOP followed by involved site radiation therapy. To try to, go for a cure. I think that should be reasonably well tolerated, even in someone of this age. We don't know, performance status and other issues, but I think that would be the preferred approach.
Oh yeah, I'll echo what Dr. Thurman says. My approach would be the same. Limited approach with a few cycles with the R-CHOP and some involved field radiotherapy. There is some other data that we do have that says it's a trial that was called the FLIER trial, where we took older patients with early stage large cell lymphoma and just gave them chemotherapy alone, with or without the radiation. And actually, survival was really no different with the radiation. So one option is 4 cycles of R-CHOP therapy without the radiation. In this case, I probably wouldn't do that. I feel that this patient probably should get some radiation because of the cutaneous involvement is unusual. As you know, Dr. Thurman mentioned, extranodal disease, these kind of things are not normal presentations. So it's early stage, but it's 1E. I do some radiation there. The other question that you had was if we would treat this, like large cell lymphoma, cutaneous large cell lymphoma leg type. I don't have any evidence to say that this is leg type. It can happen above the diaphragm, but typically it doesn't. It usually does happen in lower extremities. And the pathologist can often help us with that by looking at the cells and their aggressive presentation histologically. I wouldn't treat them necessarily any different, but I would know that if we thought this was kind of leg type, we'd be worried about much, much more aggressive disease down the road.
Any specific thoughts on how many cycles of R-CHOP prior to repeat imaging, or what would sort of guide specific duration of therapy for a shorter course with plan to involve radiation therapy subsequently?
Well, I would say typically 3 cycles of R-CHOP would be sufficient. It would be possible to re-image with PET.
Dr. Schuster, in terms of the PET, would the recommendation just be to make sure they order a whole body PET CT instead of something that's skull based?
Yeah. Make sure when they protocol it, they know that there's a scalp lesion. And then the other possibility is, the brain normally has intense FDG uptake. So sometimes that could get overlooked. So it's worth, a phone call saying, hey, there's a scalp lesion, did it cover the vertex? But at least to make sure that next time that area is covered.
Sort of a unique presentation, a 1E involvement. And so the summary recommendation would be to favor a course of R-CHOP systemic therapy, a shortened course, possibly 3 cycles, followed by repeat imaging, and likely subsequent involved field radiation therapy to try to cure this patient. So another patient, 61-year-old female with a history of relapse refractory non-germinal center activated B-cell type diffuse large B-cell lymphoma. So another relapse refractory DLBCL. This patient was originally treated with rituximab and CHOP, R-CHOP with intrathecal chemotherapy for 4 doses. Underwent a PET which showed complete response. This is a recurrence 9 months later, which was treated by 2 cycles of rituximab, gemcitabine, cisplatin, and dexamethasone, with unfortunately clear disease progression by PET CT after that salvage approach. So the question will be, what would be next therapeutic options to consider, and what factors might influence that? And so we have some imaging to review with Dr. Schuster.
So here we could see, multiple foci. Here's our retroperitoneal mass, which has been shown to be progressing through therapy. There are some nodes in the neck. We could see left axillary node as well. And on the report, there were also some FDG avid foci in the skeletal system.
Okay, so I'll start with Dr. Pagel. Any thoughts on next approach for this patient who's unfortunately experiencing very aggressive, now refractory disease behavior through the salvage approach?
Yeah, this is a tough situation. This is one where historically we've done very, very poorly. But I think that's changed a little bit, and I'm hoping in the future it continues to more positively evolve. So this patient is chemotherapy refractory. Probably changing chemotherapy regimens here is not going to get a lot of benefit. You can nominally change the regimen to something else from what this patient received, and I can't remember what it was, but it's not going to probably do great. So I'm sorry. Yeah, thank you, Peter. Okay, it was R-CHOP, and then patient got GCD, and that was a very reasonable regimen to give in that salvage setting. But of course, Deauville 5, it didn't touch it. In fact, got worse, I guess. And so I'm not going to give more chemotherapy to this person. I'm going to probably treat this patient with an ABC subtype large cell lymphoma with lenalidomide and rituximab. The R-squared regimen in this type of patient can be actually quite successful. It can take a little while, but we've seen many patients do very well and achieve really good remissions to allow them for the more longer term plan, which you have to think about in this patient as well. And this is a patient where I was alluding to earlier with a prior case who's relapsed very quickly, 9 months after standard R-CHOP chemotherapy. And actually this patient's very chemotherapy refractory. I'm going to try and get this patient for sure to a CAR T-cell treatment as soon as I can. The problem will be, at least to this point, is that to get the CAR T-cell treatment, you have to have failed 2 prior lines of treatment or failed a transplant. So this patient, needs to get R-squared. This patient needs to be followed very, very closely. Hopefully they get a good response and a good remission that's lasting. But once you start seeing things change, you're going to want to roll into that CAR T-cell treatment quickly. Another option, well, and I guess I should say this patient has failed 2 prior treatments. So you could get a couple of cycles. Forgive me, I was a little I misled you here. I would give a couple cycles of lenalidomide and rituximab, reevaluate with a PET scan, and if things are looking good, then I would try to move directly to a CAR T-cell treatment.
Dr. Thurman, your thoughts, are they similar to Dr. Pagel's in our targets?
Yes, I agree with Dr. Pagel. This is obviously a very challenging situation in that this patient is very refractory to conventional chemotherapy. I think that the goal should be to try to get her to CAR T-cell therapy. And the question is, what's the best way to do that while you're waiting, assuming that you can get her approved and ready for CAR T-cell therapy. I agree with lenalidomide in that this is an aggressive ABC subtype. The patient's had a lot of Rituxan already. Will R-squared help, or just lenalidomide? Probably wouldn't hurt to continue the rituximab. Another chemotherapy approach that might make sense is the Part B of the hyper-CBAD. So clearly she's resistant to cytotoxic chemotherapy drugs. Some people in this setting will respond to high-dose Ara-C and methotrexate, in that the mechanism is a little bit different. Although I wouldn't, have a high hope for a great response to that. I think if your center has clinical trials available, this would be a really good clinical trial candidate, since she's refractory to and has relapsed quite early. But again, I think the goal here really should be CAR T-cell therapy and trying to maximize her chances of being in a state of lower level disease than she is right now.
Right. So just to summarize, unfortunate scenario with a patient who's 61, who's progressed shortly after R-CHOP and now progressing through with rituximab with gemcitabine, cisplatin, and dexamethasone. Thoughts that, changing at this point to another chemotherapy, cytotoxic chemotherapy, is likely to be of somewhat limited benefit, although there may be some options like Part B of hyper-CBAD with some differential approach that might have some benefit, but maybe favoring something like a lenalidomide-based salvage, given that they're ABC type, rituximab with lenalidomide, towards, ideally getting the patient to a CAR T-cell therapy, or considering a clinical trial, which would certainly always be a reasonable thought in a patient who needs an exploratory approach, but CAR being the favored way to go.